Hello everyone, welcome to the next edition of Facebook Live. As you know, this comes from Dr. Mohan's Diabetes Specialities Center, and this is part of our World Diabetes Day plan. This time we wanted you all to meet all our doctors, all our consultants who are so talented and so knowledgeable that I thought that instead of just me talking to you all, they would all get an opportunity and I will be asking them questions and they will be answering. So as you know, every day we have kept one theme. For those of you who attended yesterday, it was all about insulin, a little bit about type 1 also, but mostly on insulin. And today we are going to have about the complications of diabetes, the various tests that you do for diabetes, and the tests for the complications as well. Now, this is very important for us because unlike other diabetes centers, we were the first, probably in the world, to call ourselves a diabetes specialities center. Now, why did we call it? Everybody used to say diabetes hospital, diabetes center, but we called ourselves in 1991 itself, 30 years ago. We said we are a diabetes specialty center. The reason is we decided even at that time that we will focus not just on diabetes, but all its complications, particularly on the prevention of these complications. And last year on World Diabetes Day, which is November 14th, so next Sunday, coming Sunday is World Diabetes Day. As you know, it coincides with the birthday of Frederick Banting, Dr. Frederick Banting, the man who discovered insulin. And so on World Diabetes Day last year, 2020, I gave to India a message saying that my dream is to have a diabetes complications free India. And that is the theme, and that is the purpose for which we at Dr. Mohan's are working, not just to control your sugar by hook or by crook, but to make sure that we help you all to have a long and healthy life despite diabetes. This is not rhetoric, this is not empty words, but we have hundreds now of people who have lived up to 90 and some even crossed 100 years of age, and they are doing well. Both type 2 as well as even recently type 1 diabetes. The first patient is almost reaching 90 years of age. So it's possible to have a long and healthy life. And today I would like to introduce all my consultants who are working with us. All of them are from Chennai, from the branches at Chennai. Some are from Gopalapuram and some are from Tambaram and also from Porur and so on. So from Gopalapuram, we have Dr. Lovelena. Can I see Dr. Lovelena there? Okay. So that's Dr. Lovelena Munawar. Hi, Lovelena. And we have next Dr. P.K. Gupta from the Tambaram branch. Welcome, Dr. Gupta. Then we have from the Porur branch, we have Dr. Honey Evangelin. Hi, Honey. Then Dr. Partha Sarathy, Dr. Partha from our Gopalapuram branch. Dr. Uthra from our Gopalapuram branch. Then we have Dr. Ramu again from our Gopalapuram branch. Dr. Chandru again from Gopalapuram branch. And finally, Dr. Selvakumar from our Tambaram branch. Welcome to all of you. Let's get straight on to the topic because I'm sure people are waiting to listen to all of you. We'll keep it very simple so that people can understand. So let me start with Dr. Lovelena. What are the blood tests needed to diagnose diabetes first? Let me start with that.
Good evening, sir. Good evening, all. So there are many tests are done to diagnose diabetes, but the foolproof test is the glucose tolerance test for the diagnosis of diabetes. So when you want to diagnose a patient with diabetes, if they walk into a center in a random state, that is a non-fasting state, then we will do a arterial blood sugar and the capillary blood sugar, and if it is more than 200, then we can do other tests like a fasting postprandial and the HbA1c. HbA1c is a 3 months glucose average test. With that, we'll be able to find out whether the patient is recently developed diabetes or he has diagnosed with diabetes. He has got diabetes long before or recently diagnosed with the diabetes. Or if the patient comes to our center with a fasting state, not on any medications, if the patient is not diagnosed diabetes elsewhere, then we can put them on a glucose tolerance test. We have to challenge them with the 75 grams of anhydrous glucose, and we have to check the blood sugar at the fasting state and every 1 hour, 0, 1, 2, and third hourly. And this is the foolproof test for the diagnosis of diabetes. And we can do a fasting blood sugar testing. We can do a postprandial blood sugar testing. If the fasting is more than 126 milligram per deciliter, we diagnose diabetes. And if the postprandial, that is the random or the postprandial, if it is more than 200 milligram deciliter, we can diagnose diabetes. If the HbA1c, that is the 3 months glucose average test, if it is more than 6.5, we can also diagnose diabetes. But whatever it is, by doing a glucose tolerance test, we will be able to diagnose the diabetes and the pre-diabetic state as well. Thank you, sir.
Thank you, Dr. Lovelena. Let me now move to Dr. Gupta. Dr. Lovelena mentioned the tests for diabetes. So for diagnosing diabetes, fasting, postprandial random, HbA1c, GTT, she mentioned all that very nicely. But when they come to our center, we do some additional tests. And people don't understand why we do these tests. They think we're just doing it just to make a lot of tests. Can you very simply explain, Dr. Gupta, apart from the glucose test, what are the common tests which we do? HbA1c and glucose test she has covered. But what are the other common tests that we do very briefly and why they are done? You can unmute, Dr.
So as Dr. Lovelena said, once you diagnose diabetic, HbA1c between 5.6 to 6.4 for pre-diabetes, once HbA1c touches 6.5 and above, it's diabetes. So then we have to find out where the patient actually diagnosis, whether it is type 2 diabetes and type 1 diabetes and other types of diabetes depending on the family history. So we have to, so as we talk about precision diabetes, we have to be doing some additional tests to diagnose the patient where actually he fits in. Gestational diabetes we have hybrid diabetes, we have LADA, we have ketosis prone type 2 diabetes we have. So additional tests apart from the fasting, PP, HbA1c, we initially, if there is any doubt, if the patient is state case of type 2 diabetes, then lipids and kidney profile and lipid profile on ECG will be fine. If there is any doubt in diagnosing patients, like we have confusion between type 1 and type 2 or MODI, then if the detailed family history can be taken, we can send the sample for genetic studies also. I think C-peptide test really gives an important test to diagnose the patient between type 1 and type 2 and LADA and type 2 also. So these are all the additional tests I can recommend. And if the patient needs complete evaluation, as we know, we are we famous for the all facilities under one roof. We can do the retinal screening, neuropathy screening, nephropathy screening, and cardiac screening, etc. Thank you, sir.
Thank you, Dr. Gupta. And of course, apart from that, even the blood test itself, we have the lipid profile, the cholesterol, triglyceride, good cholesterol, bad cholesterol. Each of them has their own significance. We also have the liver function test. Liver, is an important organ often forgotten, but fatty liver is associated with diabetes. And one of the indication fatty liver is your SGOT, SGPT goes up. So you can find out whether somebody has got fatty liver. And of course, the ultrasound test will tell you about your kidney, about the liver, whether any other problem is there in any of the organs. So that's another test which can be done. The echo test will tell us about the heart. And in the blood test itself, there are other tests like the electrolytes, the sodium and potassium. The reason we do that is in old people, for example, the sodium is very low. There'll be confusion and they'll be thinking, they're getting totally confused. People will think there's some brain problem or something. It could be a simple salt problem. And if you just give them salt, they become okay. So these are all routine tests. And people think, why are you doing all these tests? Each test has a significance. Yes, Dr. Uthra.
Go for thyroid. Yeah, sir, it's unmute already.
Yeah.
If the patient is obese, and we can do thyroid function test also for all diabetic patients. And once in lifetime for type 2 and for type 1 patients every year we can do thyroid function test.
Exactly. So I think we've got a flavor of all the different types of diabetes that we do. Honey, Dr. Honey, when people come to our center, we often ask them to have an eye test. And people say, I just changed my glasses. I didn't come here for glasses change, So why are you, testing my glasses? Simply you want to test my glasses power. I just changed it last week. And so can you explain why in a diabetic center we give so much importance to the eye and what that eye test is all about?
So eye test is totally different from the diabetic retinopathy test. Its eye test is basically a specs what we are wearing with powers we are checking it. But in a diabetic center, for diabetic retinopathy, dilated uh, uh, retinal retina we have to see with the scope. So to rule out any vessel abnormality in the retina.
So that is called as diabetic retinopathy. And so the eye test is done to find out whether in the back of the eye, the lens is in the front of the eye. This is in the back of the eye, whether the blood vessels are normal. And if they are abnormal, it means that diabetes already started affecting the blood vessels. So the eye test is a very important test to be done at the time of diagnosis in all patients with type 2 diabetes, within 5 years after diagnosis in a type 1 patient, and annually thereafter. So every year, even if we forget, you should come and tell us, patients should come and tell us, sir, my eye test is due. Please do it. I think the patients themselves should come and ask for that. Let me now move to Dr. Partha Sarathy. Infections are quite common in diabetes, isn't it? What are the types of infections which normally occur in diabetes, and why do these infections occur, Dr. Partha?
Yeah, the infections occurs because someone keeps the blood sugars not under control. Usually that happens. And the common infection among the elderly women are urinary tract infection, which we see nowadays. So the postmenopausal ladies with the uncontrolled high blood sugars, they usually come up with the urinary tract infection symptoms like pain during the micturition, fever, nausea, and all. So these are the common infections. And other than that, if the patient is not having a control, if they eventually develop the neuropathy and the peripheral vascular disease, even that may get an injury in the foot, which is not noticed by the patient, and eventually that the patients can have a foot infection. So these are the infections which we commonly see. And even any infection, that respiratory tract infection is also common because the diabetic itself is immunocompromised patient. So any patients can easily get the other infections like respiratory tract infections is also common, like bronchitis, even the pneumonia is also common in diabetic population. That's why we suggest the patients to take flu shots at least to prevent the flu infection. Now this Cambodia strain is also now is appeared now. So now that the new flu shot, which is containing the Cambodia strain, is also recommended to take flu shots every year for all the diabetic patients. So these are the common infections which we see nowadays. The major infection is predominantly that the urinary tract infection is a common in a diabetic population.
Thank you, Rapaz. Of course, you should also rule out TB, which is very common in diabetic patients, much more common. And as Dr. Partha said, if you control the diabetes well, you can prevent these complications. Dr. Uthra, talking about infections, we have had a terrible pandemic which is going on still. That's COVID. Mute, please. Okay. Dr. Uthra, when COVID came, we learned as diabetes center also, we learned a lot about COVID. So what is the connection between diabetes and COVID? Can COVID make diabetes worse, and can diabetes make COVID worse? In other words, a bi-directional relationship. Can you throw some light on that?
Yeah, thank you, sir, for the question. And I think it is related to the previous question also, like it is a vice versa relationship. Any infection and diabetes, it's kind of, a hen or the egg story kind of. Sometimes the infection will worsen the diabetic hyperglycemia. The hyperglycemia can worsen the infection. So it should have to be a hand in hand. So if, in terms of COVID, I think you can really categorize that already they had diabetes already, and over diabetic developing COVID infection, be it type 1, type 2, or any other form of diabetes developing a COVID infection, how it can impact their glycemic status. And another interesting group is the newly diagnosed post-COVID diabetic population. That's also, we do have, our center does have a number of newly diagnosed post-COVID patients that can be due to the stress involved with the COVID, the treatment profile, that is the steroids or infection as such. So basically, there might have been a pre-diabetic infection or the stress factor, or the steroids and the treatment profile can make them develop newly diagnosed diabetes. When in an overt diabetic, already present diabetic, be it type 1 or type 2, as I did mention, any infection can worsen the hyperglycemia, and thereby the sugar levels can go up. And same way, if the blood sugars are not under optimal control, that can really reflect on the prognosis of the disease as such also. So the positive impact of COVID, getting a positive story walking out of the hospital, 100-year-old walking out, or even 40 or the lesser age groups are coming to it, can be one important factor can be hyperglycemia here. So the control of blood sugars, and of course the comorbid factors like hypertension and the other cardiovascular can also play a role.
Thank you, Dr. Uthra. Let me now move to Dr. Ramu. So, Dr. Ramu, what is diabetic neuropathy? People often hear this term neuropathy. Is it common? What are the symptoms, common symptoms, and how do we assess it at our center?
Yeah, in fact, diabetic patients do have presented with initially diabetes symptoms. These are the symptoms the patients presented, and with this symptom only we used to diagnose diabetes. So the symptoms of diabetic neuropathy usually presented like burning sensation in the legs, pain or prickling sensation in the foot, or any neuropathic pain in the joints. So all these will consider as a diabetic neuropathy. This is highly very much visible in patients with high sugar, especially SBNC of more than 10% or 9%. They are coming in the symptom, and when we treat them with the diabetes control, usually these symptoms will come down. So the diabetic neuropathy will be diagnosed initially with a simple test called biosynmetry, where we can have simple method of measuring the diabetic threshold in both the legs, and we can able to detect the severity of the disease, whether it is a mild or moderate or severe neuropathy. So according to the severity and diabetes control, the symptoms can be relieved very easily with newer treatment is available.
Thank you, Dr. Ramu. I think you have a very clear instruction. Dr. Chandru, you have done a lot of research on obesity and diabetes. Can you explain in very simple terms how obesity makes diabetes worse, and how by correcting obesity, what are the advantages that you can get?
Yes, sir. So, obesity can lead to diabetes in many ways. One of the important factors is when there is a obesity, there are certain hormones in the blood which is secreted by these fat cells can lead to insulin resistance, as well as a decrease in the insulin secretion from the beta cells. We all know that in a healthy person, there will be only particular amount of insulin will be secreting every day to counteract the rise in the blood sugar. With people with obesity, they develop insulin resistance. Insulin resistance means there will be enough production of insulin, but it won't work properly. So when people do like physical activity like weight reduction or some exercise, any type of exercise, they start losing weight. The insulin resistance will be improving, and they will have a good amount of control. Apart from that, obesity also has obesity-related disease, like you have cardiovascular disease, then cholesterol will be very high, then joint issues, so on. So whenever there is a obesity, we have to lose the weight. That is the first thing. And second thing, we have to choose the drugs that is treated to diabetes. Like if you put on insulin, that will worsen the obesity. So we have to choose the drug which is weight neutral. That is very, very important. Now we have drugs like SGLT2 inhibitors, which can excrete more glucose in the urine. So thereby you can reduce weight as well as you can reduce the blood pressure also. Apart from that, you have another group of drugs called GLP-1 analog. So that will reduce your hunger, that will induce more satiety, it will lead to weight loss and so on. So obesity obesity can lead to worsening of diabetes. So there are many ways to lose weight. One is diet, physical activity, and we also have bariatric surgery. So bariatric surgery can lose weight in a very, very short term, and you can be free from diabetes and also free from hypertension, then dyslipidemia, and so on. So nowadays, I see a lot of advertisement coming for weight loss, particularly from paleo diet and newer types of diet. So we have to see whether it is feasible and whether it is going to be consistent, because some of these diets can lead to malnutrition and all sort of decrease in immunity and infection. So I see in my practice a lot of people going for different types of diabetes. So they can lose some weight and it is not sustainable. So once they stop those diet, they regain and it's going to be a very big problem. They put on double the amount of weight than what the original weight loss was. So we have to be very careful when seeing this fancy advertisement coming that we'll reverse diabetes and we can cure diabetes and all. You have to be very, very careful with this sort of advertisement. I think whatever you'll be able to do in a sustainable way for a long term, you have to choose that particular diet or exercise. So somebody will tell that paleo diet, you cannot stop eating rice or wheat for a longer time. You can use for maybe 3 months, but for lifelong, it's going to be a very big challenge. And apart from that, some of them, they recommend some oil, then high fat diets. They tell that to take, this butter coffee and all. So this is going to have a very bad impact on your cardiovascular system, and long term, you cannot sustain that. So we advise to choose a diet which is sustainable and which will cover all the macro as well as micronutrient composition. That is very, very important.
Thank you, Dr. Chandru. I think you very clearly explained, and all the questions have started coming in the chat box about reversal of diabetes. So whatever, it's very easy to reverse diabetes. If you lose 10 kilos in weight, you'll reverse diabetes. But then very easily it'll come back. And as you said, it can come back with a bang, can come back with a vengeance, just like cancer comes back. So we really could not even call it as reversal. We should only call it as remission. Temporarily, it's gone to a remission. You're like hiding it, masking it, and then it'll come back again with a bang. And that has been our experience, and I think the experience of everyone. So, Dr. Selvakumar, I want to ask you, Dr. Ramu talked about neuropathy. I would like you to talk about another problem which affects the foot, and that is peripheral arterial disease or peripheral vascular disease. How is this different from neuropathy, and which is more serious, peripheral vascular disease or neuropathy?
So I think peripheral vascular disease is very dangerous because it affects the larger vessels of the patient, because it mostly occur in the smoking where the cholesterol levels are very high, and again already the patients have likely to have more cardiac problem and stroke problem because of the other macro vessels also we have to look into, because it is more problematic, because once they clog in the blood vessels in the lower limb, the patients are likely to lose their limb. They have to go for amputation. So definitely it is a life-threatening condition, because we do a Doppler scan, and the earlier stage also, like mild, moderate, severe, the ABI index we do in our center. So look at the ABI center, look at the peripheral pulse. Once they walk into their center, we also examine the peripheral pulses of the foot, like dorsalis pedis, again posterior tibial, higher up in the popliteal. All these vessels we have to palpate. If once the palpation is good, then we subject them for Doppler study. Once the Doppler comes as a 1.0, then we take it as the person's pulses are good. If it is reduced, again tell them to go for sophisticated arterial Doppler to find out the where is the exactly block under this one. So definitely the prevention, we have to tell them to control the sugar, cut down the alcohol intake, control the hypercholesterol level, LDL, bring it below 70, and put them on statin to prevent the again claudication. And again, if tell them to stop smoking, so by that you can prevent the complications, or you can the progression of the disease, you can halt it.
Thank you, Dr. Selvakumar. You covered all the points. And of course, smoking and tobacco, it goes without saying that is very bad for peripheral arterial disease. The other thing about peripheral arterial disease is once you have peripheral arterial disease, it also indicates that you probably have coronary artery disease. Because as you mentioned, the same blood vessels affect the heart as well as the brain. And that's why a simple test like a Doppler, which is done routinely every year, we do it at our center. It helps to predict what else is going wrong in the body. Lots of questions started coming in the chat box, but we'll go a quick rapid fire kind of questions to all the panelists once again. So let me start with Dr. Lovelena again. We mentioned about neuropathy and we mentioned about peripheral vascular disease. But in the diabetic foot, what we worried about ultimately is an ulcer formation. And once ulcer formation occurs, whether it will heal or not is a big question. And as Dr. Selvakumar said, a peripheral vascular disease makes it more dangerous because it may not heal at all. So how can we prevent diabetic foot ulcers? Some simple do's and don'ts to prevent diabetic foot ulcers, Dr. Lovelena.
Yes, sir. So diabetic foot ulcers can be because of the diabetic neuropathy, and the ulcers become non-healing because of the peripheral vascular disease. It is the ulcer becomes a problem because of the combination of two problems, both peripheral vascular disease and the diabetic neuropathy. So how do we prevent this? First of all, we have to control the blood sugars, and we have to try to keep the blood sugars at the right level, and the HbA1c less than 7 or at least 7.5. And number two is always prevention is always better than cure. So we have to try to prevent the complication by keeping the sugars under good control, and we have to do the annual checkup for the foot. We have so many tests for the foot to assess the foot, like foot pressure study, foot examination. A simple foot examination with by a nurse can detect the diabetic neuropathy at an early stage. A Doppler test to see the blood circulation is just a very simple and very cheap test, and the biothesiometry can be done to diagnose a neuropathy at the early stage. And if at the later stage, if needed, we can do something called a nerve conduction study to read the complete circulation. How does it nerve got affected, and everything can be read. And these tests are the simple tests to diagnose the diabetic neuropathy. And by doing that, we'll come to know about the diabetic neuropathy at the early stage. So we'll be able to prevent by doing simple things. Simple things like examining your own foot daily basis, regularly, because in diabetic neuropathy, what happens? They will lose the pain sensation and they lose the temperature sensation. And so what happens? They will not be able to identify whether they have got injured or not, because there is the less pain sensation. So what we have to do, we doctors instruct the patients to check the foot on regular basis. The simple checkup like keeping examining the toes, the area between the toes, and take a mirror and see the foot, see the sole of the foot, see the dorsum of the foot, whether they have got injured or any cracks or any calluses or any corns. So if in that case you have to reach the doctor, you should not use the simple corn caps and other things, or you should not try to remove with the help of the pumice stone or other rub, which is basically used by the people at home. But if you should reach the podiatrician, or you should reach your diabetologist, they'll be able to find out whether it is a callus or corn. If you're able to prevent a callus or corn, or these are the thing which is getting converted into the pressure sores. These are the thing which is getting converted into the diabetic ulcers. Or these things can be prevented by doing a simple test at home by examining your foot. And other skin infections like intertrigo can be diagnosed by just examining your area between the toes. And this is how we prevent the diabetic foot disease and foot diseases. And apart from that, and wearing a proper shoes.
That question I'm going to ask to the next Lovelena. Thank you. That's my next question to Dr. Gupta. So Dr. Lovelena very nicely explained all the do's and don'ts about diabetic foot. Now I would like you to take over from there. We do provide specialized footwear at our center, both for men, for women, chappal, shoes, everything. What is the role of the special footwear, and why should people with diabetes wear these special footwear? How does it help? Dr. Gupta, you can unmute.
So in continuation with Dr. Lovelena, and a patient with high risk foot, we have to examine the foot every once, even though the patient doesn't complain of any problem. I think the patient above 65, 70, we have to educate the patient to look the foot daily, and plantar aspect we can't see properly, and we can use the mirror to see any color change, swelling, and all those things. And we have to examine so that we will not miss any con and all those other things. Regarding footwear, I think we have foot pressure study which tells us where the pressure points are high, so that I think if you are using the proper footwear like MCP or MCR, just equally distribute the pressure over the feet, so that the chances of getting calluses and cons are very less. And footwear should be more roomy. It should not be tight footwear. We should not be strapped. We should be sandals with more of Velcro. So those kind of footwear should be advised. And people with high risk foot, we have to recommend the footwear, one pair in the home and one pair while going for walking and all those things. By this proper footwear, patients' risk of ulceration can be minimized. Thank you.
Thank you so much. Dr. Hani, a very simple question to you. How often should a person come for follow-up to the diabetic clinic? What is the ideal for them to come? Once in 2 months, 3 months, 6 months, 1 year? How often should they come?
So once in 3 months is ideal to look for other complications and look for the other and go for the other tests for diabetes. If they are under good control, they can come for after 6 months also. If they have complication, to prevent complication, for every 3 months once they have to come to our center to check routine investigations like HbA1c and fasting PP, kidney function test and liver function test, and an eye test, and also for the foot examination study.
Yeah. So once a year, all those tests have to be done. Once in 3 months, at least the fasting PP and HbA1c have to be done. Now, people may ask, very far away, how can I come every 3 months? I have to come from Dubai. I have to come from Jamshedpur. I'm coming all the way. How can we come? Today with telemedicine, we can tell them that now the telemedicine legalized. You get the test done in your center. If there is a branch of our center, now we have 50 branches all over India. We have in Calcutta, we have in Bhubaneswar, we have in whole of Andhra, all the 5 southern states, we have in Puducherry. So if you're coming from any of those places, get it done in our own lab, then the standardization become very easy. Otherwise, get it done in some other lab and write to us, email us, WhatsApp us. We'll be very happy to get through to you. But the frequency of follow-up is very important. And the reason for that, I'll explain. Suppose the HbA1c goes from 7 to 7.5 after 2-3 months. You won't know if you're not checking. Then it goes to 8 after another 3 months. Then also you will not know. So 6 months is gone. Then it becomes 8.5 after 9 months. Then also you don't know. Then it becomes 8.5 or 9%. Oh, when did it become 8.5, 9? It didn't become overnight. It went slowly. You missed it because you didn't check up. We told you to check up. You didn't check up. So that is the reason why you need to have these repeated checkups. Let me ask Dr. Partha, diabetic kidney disease. Everybody is scared about the kidney. Will I need transplant? Will I need dialysis? Will I need anything? What are the simple tips to prevent diabetic kidney disease? First of all, will every diabetic develop diabetic kidney disease?
Yeah. So just by keeping your blood sugars under control and keeping your blood pressure under control, you can even prevent a diabetic kidney disease. And routinely, we can even screen the diabetic kidney disease by doing a simple urine test called microalbuminuria. So that test can be even picked up earlier. If the blood sugars are not under control or BP is not under control, we can bring it down to the normal range so that we can even minimize or revert back the microalbuminuria to the normal albuminuria so that we can even prevent that kidney disease. So these are the very important tools which you have to educate the patients to keep the blood sugars under control and blood pressure under control, and we can even prevent the kidney damage. Even though patients having the overt nephropathy, like proteinuria more than 1000 milligrams, by just advising them to restrict the protein intake of 0.8 milligrams grams per kg body weight, can even minimize the kidney damages further. So this is how we can even prevent the kidney disease or nephropathy.
Excellent. Dr. Uthra, I know you have a special interest in gestational diabetes, and after 2 days, we are actually going to have a special program on gestational diabetes on the 10th of November. But tell us a little bit about gestational diabetes. In other words, which pregnant woman should be screened, and why is it important to screen for gestational diabetes?
Yes, sir. Pregnant women in India, if you take off, because Asian Indians have a very high risk of developing diabetes. So it is either a universal screening or a high risk screening globally. But when we consider as an Indian subject, I think it is universal screening. At least if wherever possible at the first booking. If not, at 24 to 28 weeks, definitely you'll have to ask for a GTT to be done, and just not a blood sugar testing and a GTT, a glucose tolerance testing is the test which need to be done if they haven't been diagnosed diabetes prior to that. So that, and it is now it is kind of standardized and easier. It's only as Dr. Lovelena explained, it's 75-gram oral glucose. It's the same for pregnant or a non-pregnant, and only the values are going to be different. So it is you don't need a specialized lab or anything to go and get your GTT done. So any standardized center like ours which does a GTT would will suffice to check your whether when you're pregnant, whether you're diabetic or not. And it is very important that you check whether you're diabetic or not. And I think it can go on about GDM, but I think one important point is that if they say it is a transient diabetes, so it gets away after delivery. Yeah, in most of the cases, yes, but the risk of developing it's very, very high. And what most women do miss is to check it 6 weeks after their delivery. Definitely, even if their sugars become normal post delivery, they'll have to do a GTT again 6 weeks post delivery, which is very important to prevent their further risk of developing, of seeing whether they're already continuing to be diabetic or later on risk of diabetes. And thereon annually getting it checked GTT, because the risk of developing diabetes after gestational diabetes is quite high. And I know there's a lot more to talk about, but in want of time, I would stop here.
Thank you. That's good. And we'll reserve the other questions day after tomorrow when we look at GDM. Dr. Ramu, many people are confused whether they have type 1 diabetes or type 2 diabetes. Every time I'm asked this question. So can you say some simple tests which can confirm that somebody has type 1 diabetes? What are the tests that we do?
So actually, type 1 and type 2 can be classified as per the C-peptide. And we know that type 1 diabetes usually present in the younger population, right from the young age. And with C-peptide, we can able to diagnose very easily type 1 diabetes. So usually type 1 diabetes people will have absent C-peptide, and which should be confirmed with certain special genetic test. First of all, we should do GAD antibody test and zinc transporter test, which should be confirming again the presence of type 1 diabetes. So the presence of these two antibodies, GAD antibody and zinc transporter test, eventually will confirm the presence of type 1 diabetes as per the antibody value. If both are confirmed high values, then we can say they are type 1. Suppose they are negative, means we can go get for testing for the other monogenic diabetes category, for testing called Moody test, etc.
Thank you, Dr. Ramu. There were some people who are asking, தமிழ்ல சொல்லுங்க சார், எங்களுக்கு தமிழ்ல தான் புரியும் என்று சொல்லிட்டு they said. So அந்த கேள்விக்கு பதில் வந்து சிலதெல்லாம் தமிழ்ல ரிப்பீட் பண்றோம். அதாவது டைப் 1 டயபெட்டிஸுக்கும் முதல் வகையான நீரிழிவு நோயும் ரெண்டாவது வகையான நீரிழிவு நோய்க்கும் என்ன வித்தியாசம், எப்படி அதை கண்டுபிடிக்கிறதுன்னு கேட்டோம். ஸோ அதுக்கு பதில் என்னன்னா, சி பெப்டைட் ஒரு டெஸ்ட் இருக்கு. சி பெப்டைட் என்னன்னா, உங்க கணையத்துல இருந்து இன்சுலின் சுரக்கிறது எவ்வளவு சுரக்குது, நார்மலா சுரக்குதா, கம்மியா சுரக்குதா, ஓரளவுக்கு சுரக்குதா. ஸோ இந்த சி பெப்டைட் டெஸ்ட் வந்து டைப் 1 டயபெட்டிஸ், முதல் டைப் ஆஃப் டயபெட்டிஸ்ல பாத்தீங்கன்னா ஒண்ணுமே இருக்காது, கொஞ்சம் கூட இருக்காது. பேங்க்ரியாஸ்ல இருந்து அந்த கணையத்துல இருந்து சுத்தமா இன்சுலினே வரல அப்படின்னு அந்த டெஸ்ட்ல கண்டுபிடிச்சா அப்ப டைப் 1 டயபெட்டிஸ் ரொம்ப எளிமையா சொல்லிடலாம். இதுவே வந்து ரெண்டாம் தரமான டைப் 2 டயபெட்டிஸா இருந்ததுன்னா இன்சுலின் சி பெப்டைட் வந்து கொஞ்சம் இருக்கும். அது இருந்ததுன்னா மாத்திரையிலே கண்ட்ரோல் பண்ணிக்கலாம், இன்சுலினே தேவையில்லை, அது டைப் 1 டயபெட்டிஸே இல்லைன்னு சொல்லிக்கலாம். அது தவிர டாக்டர் ராமு வந்து 2 டெஸ்ட் சொன்னாரு, கேட் ஆன்டிபாடி அண்ட் தென் ஜிங்க் டிரான்ஸ்போர்ட்டர். இந்த 2 டெஸ்ட்டும் வந்து டைப் 1 டயபெட்டிஸ்ல தான் இருக்கும். அதுல பாசிட்டிவ்னு வந்துச்சுன்னா அப்ப கன்ஃபர்ம்டு டைப் 1 டயபெட்டிஸ்னு கன்ஃபர்ம். ஆனா என்ன ப்ராப்ளம்னா எல்லாருக்கும் இருக்காது. டைப் 1 டயபெட்டிஸ் 70% மக்களுக்கு தான் அந்த டைப் 1 இருக்கிறவங்களுக்கு கேட் ஆன்டிபாடியும் அந்த ஜிங்க் டிரான்ஸ்போர்ட், அப்போ சிபெப்டைட் வச்சு பார்த்துட்டு கண்டுபிடிப்போம். இது மூணும் செய்துட்டா ஓரளவுக்கு ஒரு 99% ஆக்யூரசியோட சொல்லிடலாம் யாருக்கு டைப் 1 இருக்கு, யாருக்கு டைப் 2 டயபெட்டிஸ் இருக்குன்னு. நெக்ஸ்ட் கொஸ்டின் இஸ் டு டாக்டர் சந்துரு. ஹார்ட் பற்றி பார்க்கலாம். இப்போ கண்ணு பார்த்தாச்சு, கிட்னி பார்த்தாச்சு, நரம்பு கொஞ்சம் பார்த்தாச்சு, ஃபுட் காம்ப்ளிகேஷன் பார்த்தாச்சு, இருதயம், ஹார்ட் காம்ப்ளிகேஷன் டயபெட்டிக் பேஷண்ட் அதிகமாக வருமா, அது எப்படி வந்து தடுக்கிறது? இஸ் இட் பாசிபிள் டு பிரிவென்ட் ஹார்ட் டிசீஸ்? தட் இஸ் அ கொஸ்டின் டாக்டர் சந்துரு.
Yes, sir. Heart disease usually coexist with the diabetes, because most of the people with the diabetes, they have elevated blood pressure, and they also have high cholesterol levels. Cholesterol there are different types of cholesterol. There is a good cholesterol, it is known as HDL, and bad cholesterol is mainly known as LDL. So in a diabetic patient, the diabetes people will have a different type of dyslipidemia. அதாவது சுகருக்கு உங்களுக்கு வந்து ஒரு பர்டிகுலர் டைப் ஆஃப் கொலஸ்ட்ரால் காம்பினேஷன் இருக்கும். அதாவது கெட்ட கொலஸ்ட்ரால் அதிகமா இருக்கும், நல்ல கொலஸ்ட்ரால் கம்மியா இருக்கும். பிளஸ் கூடவே இந்த பிபியும் வரும்போது என்ன ஆகுனா, இந்த அதிகமா இருக்க கொலஸ்ட்ரால் வந்து என்ன ஆகுனா போயிட்டு ரத்த குழாயிலெல்லாம் அடப்பு உண்டு பண்ணும். பர்டிகுலர்லி இந்த ஹார்ட்ல இருந்ததுன்னா அந்த ஹார்ட்ல பிளாக் வரும். அவங்களுக்கு வந்து பாத்தீங்கன்னா இந்த இஷ்கமிக் ஹார்ட் டிசீஸ், அவங்க நடந்தா மூச்சு வாங்கும், சில பேருக்கு வந்து நெஞ்சு வலி வர மாதிரி இருக்கும், டிஸ்கம்ஃபர்ட் இருக்கும். அதே மாதிரி சில பேருக்கு வந்து பாத்தீங்கன்னா பிரெயின்லயும் இந்த கொலஸ்ட்ரால் டெபாசிஷன்லாம் இருக்கும். ஸோ அதே மாதிரி காலில் இருந்ததுன்னா இந்த பெரிஃபரல் வாஸ்குலர் டிசீஸ்னு வரும். ஸோ இதை வந்து கண்டிப்பா நம்மளால தடுக்க முடியும். ஸோ மெயினா வந்து பாத்தீங்கன்னா உணவு பழக்க வழக்கங்கள்லாம் இதுக்கு முக்கியமான காரணம். ஸோ நம்ம எடுக்கக்கூடிய உணவுல வந்து பாத்தீங்கன்னா கொலஸ்ட்ரால் கொஞ்சம் கம்மியா எடுக்கிறது, அதே மாதிரி வந்து பிளட் சுகர் வந்து கண்ட்ரோலா வச்சுக்கிறது, ஸ்மோக்கிங் வந்து கம்மி பண்றது, அதே மாதிரி ஸ்ட்ரெஸ், பர்டிகுலர்லி ஸ்ட்ரெஸ், எனி கார்டியோவாஸ்குலர் டிசீஸ் வந்து பாத்தீங்கன்னா வந்து நம்ம அளவுக்கு அதிகமா ஸ்ட்ரெஸ், பர்டிகுலர்லி நம்ம வந்து ஒழுங்கா தூங்கல, ஒரு நாளைக்கு ஒரு 7 மணி நேரம் தூங்கல அப்படின்னா வந்து அவங்களுக்குலாம் இந்த ஸ்ட்ரெஸ் வந்து அதிகமா இருக்கும் வந்து. அண்ட் இந்த ஸ்ட்ரெஸ் அதிகமா இருக்கவங்களுக்கு பாத்தீங்கன்னா இந்த ஹார்ட் ப்ராப்ளம், அது மாதிரி இந்த ஹார்ட் அட்டாக், ஸ்ட்ரோக்லாம் வந்து கொஞ்சம் அதிகமாவே வரும். ஸோ ஒன்ஸ் இந்த பிபி வந்து அதிகமா இருந்ததுன்னா இவங்களுக்கு வந்து பாத்தீங்கன்னா வந்து கூடவே இந்த கிட்னிலையும் ப்ராப்ளம் வர ஆரம்பிச்சிடும். ஸோ இந்த கிட்னி ப்ராப்ளம் வந்து பாத்தீங்கன்னா எப்படி கண்டுபிடிக்கிறது பாத்தீங்கன்னா, ஏற்கனவே டாக்டர் பார்த்த சாரதி சொன்ன மாதிரி யூரின்ல வந்து மைக்ரோ ஆல்புமின் வரும் வந்து. இதுதான் ரொம்ப ஆரம்ப அறிகுறி. ஸோ அதனால நீங்க ரெகுலரா ஒவ்வொரு விசிட்டும் நீங்க டாக்டர் பார்க்கும்போது ஒன்ஸ் இன் 3 months ஆர் 6 months வந்து நீங்க பிபி, கொலஸ்ட்ரால் இது எல்லாமே செக் பண்ணிக்கிட்டீங்கன்னா வந்து உங்க கொலஸ்ட்ரால் வந்து பாத்தீங்கன்னா வந்து இந்த கெட்ட கொலஸ்ட்ரால் எல்டிஎல் அப்படின்னு சொல்லக்கூடிய இந்த கெட்ட கொலஸ்ட்ரால் வந்து 70க்குள்ளார இருக்கணும் டயபெட்டிக் பேஷண்ட். நார்மலா வந்து பாத்தீங்கன்னா 130க்குள்ளார இருக்கணும். ஸோ டயபெட்டிக் வந்து பாத்தீங்கன்னா ஒரு 100க்கு கீழே இருக்கணும்னு சொல்லுவாங்க. 70 கிட்ட இருந்ததுன்னா வந்து நம்ம இந்த மாதிரி ஹார்ட் அட்டாக், ஸ்ட்ரோக்லாம் இதெல்லாம் வந்து வராம ப்ரிவென்ட் பண்ணும். நிறைய பேர் என்ன பண்ணுவாங்கன்னா யூஸ்வலா கொலஸ்ட்ரால் மெடிசன் வந்து ஸ்டார்ட் பண்ணுவாங்க, 2 மாசத்துக்கு நிறுத்திடுவாங்க வந்து. அது வந்து தப்பு, அந்த மாதிரி பண்ணக்கூடாது. ஒன்ஸ் கொலஸ்ட்ரால் மெடிசன் ஸ்டார்ட் பண்ணா நீங்க வந்து லைஃப் லாங் எடுக்கணும். மேபி டோஸ் வந்து கம்மி பண்ணிக்கலாம். இப்ப 10 மில்லிகிராம் இருக்கிறது மேபி 5 பண்ணலாம், இல்ல 10 இருந்தது உங்க கண்ட்ரோல் வரலன்னா 20 பண்ணலாம். சில பேருக்கு 40 மில்லிகிராம் கூட தேவைப்படும். பட் நீங்க வந்து நிறுத்தக்கூடாது, அது ரொம்ப ரொம்ப முக்கியம் வந்து. அப்பார்ட் ஃப்ரம் தட் நீங்க ப்ராப்பரா தூங்குறது வந்து ரொம்ப அவசியம். அதுக்கும் உண்டான வழிகள் இருக்கு வந்து. நீங்க மெடிடேஷன் பண்றது, ஸ்ட்ரெஸ் யோகா இதெல்லாம் பண்ணீங்கன்னா உங்க ஸ்ட்ரெஸ் லெவல் கம்மியாகும். ப்ராப்பரா தூங்கணும், அது ரொம்ப ரொம்ப முக்கியம். ஸோ இதெல்லாம் பண்ணீங்கன்னா கண்டிப்பா நீங்க வந்து ஹார்ட் ப்ராப்ளம் வந்து ப்ரிவென்ட் பண்ணலாம்.
மரம்பேடு கேசவன் ஜெயராமன், நீங்க கேட்டீங்க, கொஞ்சம் தமிழ்ல சொல்றீங்களான்னு. அதனாலதான் இந்த 2-3 கேள்விகள் உங்களுக்காக ஸ்பெஷலாக தமிழ்ல சொல்றோம். இப்ப லாஸ்ட் இது கூட நான் தமிழ்லயே இப்ப சொல்றேன் டாக்டர் செல்வகுமார் கிட்ட. டாக்டர் செல்வகுமார், கண்ணுக்கும் டயபெட்டிஸ்க்கும் சம்பந்தம் உண்டுன்றது நம்ம சொன்னோம். இப்போ நம்ம சென்டரை பொறுத்தவரையிலும் கண்ணுக்காக ஸ்பெஷலைஸ் டிபார்ட்மெண்ட் இருக்குன்றது பல பேருக்கு தெரியாது. ஏதோ டயபெட்டிக் சென்டர் நினைச்சுக்கிறாங்க. ஆனா என்னென்ன நம்ம செய்யறோம், நம்ம கண்ணு டிபார்ட்மெண்ட்ல என்ன நாங்க செய்யறோம், எந்தெந்த சர்ஜரி செய்யறோம், என்னென்ன லேசர் அந்த மாதிரி, அது கொஞ்சம் சுருக்கமா அது கொஞ்சம் சொல்லிடும். கண்ணுக்கும் என்ன ட்ரீட்மெண்ட் ஆஃபர் பண்றோம் டயபெட்டிக் சென்டர்ல, அது கொஞ்சம் சொல்லிடும்.
ஸோ நம்ம பார்த்தபோது நம்ம தெரியும், இந்த சுகர்னால கண்ணு, கிட்னி, கால் நரம்புகளில் மைக்ரோவாஸ்குலர் இந்த சின்ன வெசல்ஸ் அடைபடுறதுனால வரக்கூடிய வாய்ப்புகள். ஸோ சார் வந்து கண்ணுக்கு பற்றி கேட்டாங்க. கண்ணில் வந்து முதல்ல 2 வகையா பிரிக்கலாம். அதாவது லென்ஸில், இந்த வாட்சில் இருக்கிற லென்ஸ் மாதிரி பிரச்சனை வரலாம், அது கேட்ராக்ட். இந்த லென்ஸ்ல இருந்து உள்ள இருக்கிற டயல் இருக்கு இல்லைங்களா, அந்த டயல்ல இருக்கிற பிரச்சனைங்கிறது ரெட்டினா. ரெட்டினல்ல அஃபெக்ட் ஆகலாம். அதனால என்னன்னா டைலேட் பண்ணி சிம்பிளா வந்து கண்ணுக்கு பேஷண்ட்டுக்கு பிரச்சனை வருதுன்னா கண்ணுல விழித்திரை, அதுல ஒரு பிம்பம் விழக்கூடிய ஏரியாவில் பிரச்சனை வந்தாதான் டாக்டரை பேஷண்ட் பார்க்கணும்னு நினைப்பாங்க. அப்படி இல்லாத பட்சத்தில் நாங்க என்ன பண்றோம், மோகன் டயபெட்டிஸ்ல டயபெட்டிக் ரெட்டினோபதி டெஸ்ட் ஸ்பெஷலா என்னன்னா கண்ணு அந்த பீப்புளை விரிவடைச்சு அதுல உள்ளார இந்த பார்வை விழக்கூடிய ஏரியாவில் எல்லா குவாட்ரண்ட்லயும் சுகர்னால டயபெட்டிக் ப்ராலிஃபரேட்டிவ் ரெட்டினோபதி இருக்கா, லீக்கேஜ் இருக்கா, ப்ராலிஃபரேட்டிவ் ரெட்டினோபதி நியூ வெசல்ஸ் ஃபார்ம் ஆயிருக்கா, மேக்குலர் எடிமா கண்ணுக்குள்ள அந்த பிம்பத்துல விழக்கூடிய ஏரியாவில் பிரச்சனை வருதா அப்படின்னு டயபெட்டிக் ரெட்டினோபதி அந்த இதுல டைலேட் பண்ணி கண் டாக்டர் மூலயமா அதை தெரிஞ்சுக்கிட்டு அவங்களுக்கு விவரிக்கிறோம். இந்த பிரச்சனையினால நீங்க 6 months ஒன்ஸ் ஃபாலோ பண்ணா போதும். இந்த பிரச்சனைக்கு மேற்கொண்டு டெஸ்ட் ஆன்ஜியோகிராம் பண்ணி அதுல எங்கெங்க லீக் இருக்குன்னு கண்டுபிடிக்கிறோம். அது மூலயமாவும் ஓசிடி அந்த திக்னஸ்ல எங்கெங்க உங்களுக்கு அந்த வாட்டர் லாகிங் இருக்கு, அதுக்கான லேசர் பண்ணணுமா என்னன்னு எங்கள்கிட்ட ஸ்பெஷலான லேசர் டயபெட்டிக் ரெட்டினோபதி இதே டெஸ்ட் பண்ணிட்டு இருக்க ஐ சர்ஜன்ஸ் இருக்காங்க. அவங்கள மூலயமா ஃபாலோ பண்ணி இந்த சென்டர்ல, அதனாலதான் மோகன் டயபெட்டிஸ் சென்டர் வந்து மற்ற சென்டரோட எதனால மேற்கொண்டு உலகத்திலே ஃபர்ஸ்ட் இருக்கணும்னா எல்லாமே ஒரே ரூஃப்ல பாக்குறதுனால ஒரே நாள்ல அவங்க எல்லாமே பார்த்துக்கலாம். ஐ டெஸ்ட்ங்கிறது டயபெட்டிஸ் பேஷண்ட் ஒன்ஸ் இன் இயர் அவசியம் பார்த்துக்கணும். பிரச்சனை இருக்கவங்க எப்ப ஐ டாக்டர் பாக்குறாங்க அப்ப சொல்றாங்களோ அப்ப அடிக்கடி பார்த்துக்கணும். தேங்க்யூ.
ரொம்ப ரொம்ப அருமையா சொன்னீங்க டாக்டர் செல்வகுமார். இப்போ வந்து 45 நிமிடங்கள் ஆயிடுச்சுன்னு, அதனால அடுத்த சில கேள்விகள் நிறைய பேர் பொறுமையா வெயிட் பண்ணிட்டு இருக்காங்க. ஸோ அதனால நானே அது குவிக்கா சிலதெல்லாம் எங்கிட்டே கேட்டிருக்காங்க, நான் ஒன்னொன்னா குவிக்கா அதை பதில் கொடுக்குறேன். I'll take up the questions. Mr. Manoj Kumar, see how the blood sugar chart of a normal person and a diabetic differs. See, God has given us such a fantastic pancreas. You cannot beat that. Whatever artificial pancreas we produce, we cannot beat God, and we cannot make a normal pancreas. The pancreas is so well designed by God that whatever you take, even if you take one whole tin of KC Das Rasagulla, you get directly from Calcutta, and then you finish it in half an hour, you finish that whole thing, because you'll become very sick if you eat that much. But still your sugar won't go up, because the moment your sugar goes up, insulin will come. Again you eat, again insulin will come. Then you'll say, then what's the big thing? I can eat as much as you want. The problem is you keep on doing that, your insulin will run out at some time. It's like a well, water. You keep on taking water from the well, ultimately there'll be no water in the well. So similarly, if you keep doing that all the time, it will happen. But what I'm trying to say is, in a normal person, it won't go up. That is the basis of the glucose tolerance test. We are loading you with 75 grams of glucose. Many people will even vomit after drinking. That's so sweet. But even after that, the sugar won't go up in a diabetic person, non-diabetic person. From 70, it will go to 100, 110. Then it'll come back to 70 again. Okay. Whereas in a diabetic person, it will go up 200, 300, and it won't come down. Somebody has asked about going up, and next question, Anis's question is that. So I'll come back to that. So in a diabetic person, on the other hand, first after glucose or after food, it will go up. Then the fasting itself will go up. HbA1c will go up. Everything will go up. So the diabetic sugar is there, and the non-diabetic sugar is here. And in between is the pre-diabetic stage, where you can go either there or here. So that is the difference between diabetic and non-diabetic, Manoj. So people say, if I go to diabetic center, you will make me diabetic. I wish I could make you diabetic. There is no method to make you diabetic unless I load you with steroids for next 3 months and make you take steroid like COVID patients when they're treated. Even then, for many, it doesn't go up. Only for some, it will go up. So I cannot make you diabetic even if I want to. So don't worry about that. Okay. Then next is Anis. Can a non-diabetic person go up to 300 in 1 hour and then become normal after 90 minutes, 1 hour? It's rare, but it can happen. It will happen in a condition called as dumping syndrome or elementary glycosuria. Your stomach has been cut and it doesn't get time. See, normally what happens, I said, whatever you eat, including that rasgulla, it won't go up, I said. But that is because the pancreas is getting time to sense what is happening. Oh, glucose going up, signal goes to the pancreas. Come on, come on, come on, like a fire engine. Come on, put out the insulin. And the insulin, immediately the pancreas says, yes, I'm coming, and puts out the insulin, and the sugar goes down. Okay. But suppose that signal is going very slow, we are trying to send the signal, but Wi-Fi problem, it is not going. Okay. So because the Wi-Fi problem, when the sugar is going high, it's trying to tell the pancreas, but Wi-Fi problem now. Okay. Or flood problem, you're not able to reach in time. So it goes very slowly. After half an hour, 1 hour only, it will reach the pancreas, that signal. By the time the sugar has already gone up, it's like a thief, you keep the house open and then the thief has taken everything and run away. After he has gone 10 miles only, you are realizing that the theft has occurred. How we are going to catch him? He has already run away. So like that, when your stomach is cut, completely cut and all that, or some vagotomy is done, certain other conditions called elementary glycosuria, suddenly sugar will go up. When it reaches 300 only, the pancreas realizes, oh my God, it's gone to 300. Then slow reaction. Then it will bring the sugar down. Okay, that is not diabetes. It's a different condition. We will not go into that. But very rarely it can occur, but it's not common. Then Vivek Veeraraghavan. Hi sir, can a diabetic maintain average sugars HbA1c around 7 with fluctuation sugar? For instance, I see 250 and 70 at another point. Yes, that is a problem with the HbA1c. HbA1c is good. If it is 7, your average is good, but it doesn't tell you, HbA1c doesn't tell you how the fluctuation is occur. The very fact you have done it shows you have been doing continuous glucose monitoring. So well done, CGM. Only if you do it, you will find out. You put a small patch and then you see how it's happening. You hit the nail on the head. That is why HbA1c alone is not sufficient. Two people can have HbA1c of 7. One person, the sugar only fluctuates like this. Another person, it goes that much, goes down so much. So average again comes to 7. 7 is HbA1c only giving you an average. That's all it tells you. It doesn't tell you whether it's going up or down. So to find that out, you put the AGP patch or the continuous glucose monitoring CGM patch, the sensor. Once you put that, every blood sugar in the body 100 times a day, 1400 times in 2 weeks time, it gives you graph after graph. It'll tell you how much is time in range. The time in range is, it should not go below 70, shouldn't go above 180. It should be within that range, and at least 70% of the day should be under control. So if it is going to 70 or 250, your time in range will not come in that 70%. So that is why you need the time in range. So HbA1c is useful, but it's not complete without doing this. Or is it always good to have sugars around 150? Yes, it's always good to have sugars in that range. If it is going up like this, Vivek Veeraraghavan, I don't know which type of diabetes you have, but if it's going up too much like this, we call it as brittle diabetes, and that usually occurs in type 1 diabetes because you don't have enough insulin, the C-peptide is low, so it's going very high. By using an insulin pump, you can make it almost like a straight line. So you can get the fluctuations can be avoided. So using pump or using multiple daily doses of insulin or using special insulins, you can do it. But with the pump, you can do it very well. TN friends. Hi doctor, if we take sugar medicines for longer period, is there any chance of kidney failure? This is the biggest myth in the century. Okay, and you must throw that thing out through the window, out through the window. Every time, every Facebook Live, every patient of mine asks this, and this is because the alternative system people are loading these people. Oh, diabetic tablet, your kidney will go. This is the threat that they have. So they'll frighten them so much they'll be scared to take the tablet itself. Then what will they do? They'll go to the alternate medicine fellow and then take that. As if that nothing will happen. That also contains chemical. That also will damage the kidney. I see it equally. If I say that, they'll come to hit me. But that's the truth. I see it. Lead poisoning due to that and things. So they are also chemicals. You think if it's a leaf, it is not a chemical. In the leaf also there is chemical. Okay, everything is chemical only. Everything is a molecule only. In fact, half of our medicines come from plants only. That you don't know. Metformin comes from a plant. Acarbose comes from a plant. Half of our medicine come from plant only. So a plant, you take it and make it into a medicine. Okay, if you take it as a plant itself, it's probably worse. Probably contains all the fungus of the plant also. Okay, so it doesn't mean that one system is bad, other system is good, one system is this. We are going to give you all this medicine to produce kidney problem for you. That is why we all qualified. We are coming to do Facebook Live for you to damage your kidney by giving you tablet poison. That is not what we qualified for. When we took the Hippocratic oath, the first thing we say is we will never harm the patient. That is the first oath that we take in our life. Okay. So
another myth is if the patient takes insulin, they get that's the myth. Usually the patient asks.
Insulin also. Insulin, another myth is we talked all about it yesterday. If I take insulin, I am in my last stage. I am going to die. Then what about people who took it for 85 years? Where then the last stage when they started? 90 years also people have taken. Started at 5 years, now they're 95 years, they're still taking. So what did insulin do to them? Nothing. It just kept them alive and made them go to 95. These are all myths. This is all bunkum. Okay. And you can be very strong about it because after treating diabetes for 50 years, after treating 8 lakh patients, if you tell me your medicine is going to produce side effect, show me the medicine, which is producing side effect. Show me a patient. They mistake because somebody develops, people have been taking the medicine, not controlling the sugar, kidney gets affected. Now, instead of blaming the diabetes for producing that, you blame the medicine now. Okay. It's very easy to blame a medicine. The medicine only kept you alive so long. Okay. So it will never, ever produce kidney problem. That's the answer. And please tell TN friends, tell all your TN friends and tell all your other friends, please take a microscope, take a loudspeaker and shout that. Okay. Because we want that message to go through loud and clear that it does not produce any complications. Kameshwari, how to control microalbumin, what are the other precautions, what is LADA, what are the medication? They're all different questions. I'll take it one by one. Microalbumin, I've already told you, small amounts of albumin leak in the kidney. It's a first sign of the kidney getting affected. Good news is it is reversible. You have to control diabetes, control blood pressure, take specific medicines for that. Somebody mentioned Telma or something there. So you take that kind of medicine, it can reverse it. So that first question over. What is LADA? LADA is latent autoimmune diabetes of adults. It's a very complicated term. It just simply means type 1 in adults. So if type 1 comes in adults, that is called LADA. Okay. We often mistake it to be type 2. Suddenly they develop ketosis, C-peptide goes down, GAD becomes positive, they need insulin. Oh, we are fooled. It is not type 2, it is type 1. That is called precision diabetes. Diagnosing the correct disease, diagnose type of diabetes and giving the correct treatment. What are the other medication taken along with statins to prevent complication? Control the blood pressure, control the sugar, take your statin, A, B, C, finished, over. You won't get complication. Tea and friends again. How much do a normal water should a person drink and how much a sugar patient drink? Both of you drink same amount only. Sugar person is also human being only. Okay. So just, and if your sugar is well controlled, you're just like another human being only. You're not special, species and some other special species. Everyone drink enough water. In a hot country like India, drink 2 to 3 liters of water every day. Ayurveda says drink 4 liters of water, get up in the morning, drink 2 liters of water. I agree with that. Okay. But if you have a kidney problem, a heart problem, you should restrict the water. Otherwise, drink enough water. Not only when you feel thirsty, you should drink. Keep drinking water throughout the day. It's very good for you. Mohammed Fayaz, good evening, sir. My HbA1c is 5.8. Congratulations. Kidney function test normal, but my microalbumin is 150. It means it's not completely normal. 150 means it is high. Medication, semi-reclamate, Taslock. You mentioned Taslock. Now, Taslock, I cannot treat you obviously through Facebook Live. I cannot give a prescription now and say increase Taslock to 2. I cannot tell you without even seeing your potassium, without seeing your kidney, without seeing everything. But looks like if you're our patients, reach out to us. We'll make that microalbuminuria normal. That is our job. We'll get your sugar, BP under control, adjust your medicines. Microalbuminuria is reversible. We can reverse it. If it goes to macroalbuminuria, it will become more difficult. How to decrease microalbuminuria with normal HbA1c? That's why it's HbA1c is only the HbA1c is only one indicator. Maybe your blood pressure is not under control. Maybe it's due to something else. It may be prostate. It may be urinary infection. It may be a small stone producing microalbuminuria. It may be blood pressure. It may be something else. So that is holistic treatment. So we'll have to find out, but we'll get it under control. I assure you. Diabetes and health. Recent papers suggest to SGLT2 is associated with retinal vein occlusions commonly seen. Glaucoma also needs to be ruled out. Well, when you do large numbers of studies, occasionally these things will come. So far, yes, I have seen 1 or 2 small reports on this. So far, if you always must weigh the benefits and the risk. The benefits are it prevents, it reduces your weight, reduces your sugar, reduces the blood pressure, prevents heart disease, prevents heart failure. It's a treatment for heart failure, prevents kidney damage, reverses kidney damage. So 7 advantages it has. It also has other minor side effects. It produces mild genital infection, mild urinary infection, mild drop in the pressure, mild electrolyte imbalance. So SGLT2 is not to be used like giving some mithai to somebody. Okay, you have to follow it up very correctly and bring it under control. But retinal vein occlusion, I have not seen. I have treated more than 10, 20,000 patients. I have not seen even one. Maybe I'll see. If I see another 20,000, I may see one case. But I have not seen so far. But it's been described. That's the beauty of the modern system of medicine, where even if one case is picked up somewhere, they will immediately bring it to that is called pharmacovigilance. And that is how this has come. But suppose 1,000 cases come with retinal vein occlusion, the drug will be banned, thrown out. It will never be allowed to be used in human beings again. Okay. Yes, Uthra, you're saying something.
Yes, sir. That is basically seen in CKD patients also, not the trial also that show in CKD patients.
You shouldn't have used it in that case in the first place.
Yes.
Miracle Chess. Please tell us about Twin Health. Well, Twin Health is a particular brand, and I cannot talk about one brand of people doing it. Let Twin Health continue what they are doing. And we believe in long-term solutions rather than shotgun therapies. So I will not comment about some other people doing thing. But in general, I think the point very well made by Chandru and others that reversal of diabetes is a big hype, all said and done. It looks as if everybody can be just reversed. Even if your eye is gone, still you will reverse. Kidney is gone, still you will reverse. Heart is gone, still you will reverse. That is what people are saying. Type 1 diabetes also will reverse. Everything will reverse. like a miracle, one panacea like that, and then everything will get reversed. It's not so easy. Let me tell you that after 50 years, it takes a lot of effort to reverse. You have to lose a lot of weight, and the moment you put it on, it'll come back again also, and invariably you'll put on also. These things are not sustainable in the long run. Of course, there are people who will benefit by that. I'm not saying nobody will benefit. Some people need motivation. If you give them that motivation, they will lose it. But I know of my own friends and others who have tried this. And I'm not talking about a particular program, I'm talking about in general, reversal, weight loss, this, that, going off medicines. 6 months later, they're all back and they are thing. That has been my experience. The steroid therapy, which is responsible for what? For diabetes, yes, in some cases, steroid is used to save lives in COVID-19. And steroid does have an increase in sugar. There's no doubt. Steroid is an anti-insulin hormone, but you have to use it as life-saving. Steroid has saved so many lives. But try to cut down the dose. Try to, if you're on diabetic medicine, increase the insulin or increase whatever. When you stop the steroid, the effect usually goes away. So it is well known that steroid may even produce mucormycosis, and you have to be very careful. Steroid is like using a very sharp knife. You have to be careful. You must know when to use it. An ordinary person cannot use. Surendra Gupta, arms or legs, long muscles activity can induce insulin sensitivity, more conversion of glucose and energy, and once a diabetic starts practicing, level gets boosted. 100% agreed, Surendra Gupta. So that's called resistance training. Once you do resistance training using, yesterday also we talked about it, the FAR principle: flexibility, aerobic, and resistance, FAR. All the three are very important for exercise, and they definitely have their benefit. I entirely agree with you. Diabetes in health. Does the initiation of duloxetine need assessment of IOP to rule out glaucoma? I'm not going to individual drugs, and there are better drugs than duloxetine to treat diabetic neuropathy, but it's used, and if it's used, you have to use all the precaution. That goes for any drug that you use, not just duloxetine. Hemalata Narayanamurthy, doctor, can pre-diabetes be reversed with diet, exercise, and yoga? Pre-diabetes is very easy to reverse. It's only diabetes you're arguing about. And the duration of diabetes, after 10 years, can you reverse? After 20 years, can you? That is what I'm arguing. Pre-diabetes is 100% reversible. You should reverse. We have published it. We have shown the prevention trial. We have shown the reversal trial. We have shown everything. Pre-diabetes, you're on the wall. Okay, you're on this wall. That is pre-diabetes. This side is diabetes. This side is normal. It's up to you. You want to jump this side, you jump. You'll become normal. If you want to put on a little more weight and become diabetic, it's up to you. You can. It's a free country. You can do whatever you want. Democratic country. But you have a choice. While you're there, you have a choice. No. I prefer to go this way. I'll put in a little effort. I'll do my exercise. I'll reduce some weight. I'll jump this side. Good for you. Okay. No. I don't believe in pre-diabetes. I don't think in lever do. Okay, we'll take your chance and see. 2 years later, come back to diabetes. I told you. Okay. Now we'll start the treatment. Now we'll start trying to reverse. Okay. So pre-diabetes is a window of opportunity. Don't miss that. And also remember, during pre-diabetes, already the risk for heart and other complications have already started. So Surendra Gupta, Kiliwalavan is asking about erectile dysfunction. Are they disconnected? Are they connected? Yes, thank you, Dr. Kiliwalavan, for telling us about that. We didn't mention about sexual disorders. So erectile impotence and erectile dysfunction and impotence in males and female sexual dysfunction is also common among people with diabetes. But again, it's not a very common complication if you control your diabetes. If you don't control your diabetes, yes, in middle-aged men, it is becoming quite common. It's one of the terrible complications. So better to control diabetes and prevent erectile dysfunction. Good control of diabetes. Yes.
CBD also, no, sir? They should also look out for CBD.
Coronary artery disease. It relates to blood vessel damage, neuropathy, autonomic neuropathy. So if you control the diabetes, you can prevent it. Surendra Gupta, diabetes reversal possible only if the required lifestyle is dietary habits is made a habit. But really speaking, majority of people dreaming of diabetes actually dream to eat a normal diet with sweets and mithai. This is exactly what I said, Surendra Gupta. And so thank you for supporting me. This is what I said, that human beings are human beings, And this is not today. It's not us. 2021. Many, centuries ago, there were two people called Adam and Eve. Okay. That is how life started on this earth. At that time, God came and said, don't eat this apple. And what did they do? They ate that apple only. That is how human beings are. Right from Adam and Eve, the same gene is now coming to us also. So human beings are like that. You tell them, don't eat this mithai, we'll eat that mithai only. Okay. If you tell them, don't put on weight, they'll put on weight only. So human beings are like that. So while we all have a period when we are very happy, we want to, try something. After 6 months, it's like soda butty. You open the soda bottle, it'll go. The enthusiasm will go. So once the enthusiasm goes, it's gone. The gas is gone. So like that enthusiasm goes away for human beings, unfortunately. For most people. There are exceptions who will keep on, going on and on and on and on and on. There are people like, and their sugars will also be reversed forever also. That is there, but that's an exception. Very few who are not like Adam and Eve are there also. Okay. Vishwanathan Bhaskaran, Anshul Singhai. Hi, Dr. Anshul. So waist circumference or waist hip ratio, which is better to detect central obesity? Waist is so simple. Just take a tape and measure your waist and you get it. For hip, the problem is you have to go lower down. So you have to undress both male and female. To get an accurate hip is very difficult. You need to, private place, you have to think, and then the errors are more. If your hip goes wrong and the waist goes wrong, you get double error. So instead of all that, just take a tape and measure in the waist and the umbilical area, you're done. So waist is as good as waist hip ratio. We have stopped doing waist hip ratio. We do only waist. Vishwanathan Bhaskaran, how diabetes can influence skin related problems. It's a whole chapter by itself. A whole Facebook live we can talk about it. How it produces dermopathy and how it produces NL with the necrobiosis lipoidica diabeticorum and annulogranulomere and fungus infections and bacterial infections and viral infections and all kinds of infections can come in the skin. It's a whole chapter by itself. Good news is if you control diabetes, you can prevent all of that. So control diabetes, that's better. Marambedu Keshavan Jayaraman, கொஞ்சம் தமிழ்ல பேசணும். I think you're happy நினைக்கிறேன். இதுல கொஞ்சம் ஹாப்பியா இருந்தா கொஞ்சம் போட்டுருங்க தேங்க்யூன்னு சொல்லிட்டு. ஸோ அதுக்காக கொஞ்சம் அப்பப்போ தமிழ்ல பேசணும். அனீஸ், how do sulfonylurea make worse pancreas? இது இன்னொரு மித்து. இது சல்ஃபனைலுரியா போட்டா pancreas போயிடும், அது போயிடும், இது போயிடும். ஒன்றும் போகாது. 50 வருஷமா சல்ஃபனைலுரியா தான் யூஸ் பண்ணியிருக்கோம். எங்க பேஷண்ட்ஸ் எல்லாம் 50 வருஷம் முடிச்சவங்க 60 வருஷமா முன்னாடி அந்த டைம்ல SGLT-யும் கிடையாது, ஒரு மண்ணும் கிடையாது. ஒன்லி சல்ஃபனைலுரியா அண்ட் மெட்ஃபார்மின். அதை வச்சு 50 வருஷம் தள்ளிட்டாங்க. எல்லாம் நல்லா இருக்காங்க. அப்போ போய் பேங்க்ரியஸ் போகும், இது பேங்க்ரியஸ் போயிட்டு 50 வருஷம் இருந்தாங்க. ஒண்ணுமே போகாது. எல்லாம் கரெக்டா ட்ரீட் பண்ணணும். நீங்க கரெக்டா யூஸ் பண்ணணும். கரெக்டான ஆளு இது பண்ணணும். டிரைவிங் கத்துக்காத ஒரு ஆளை கார் மெர்சிடிஸ் பென்ஸ் கொடுத்தா எப்படி இருக்கும்? அவருக்கு டிரைவிங்கே தெரியாது. அவருக்கு நீங்க மெர்சிடிஸ் பென்ஸ் கொடுத்தா என்ன பண்ணுவார்? அவர் போய் எங்கேயும் போய் இடிச்சு இதாயிடும். அதே மாதிரி தான் இது. நீங்க சல்ஃபனைலுரியா தெரியாத ஆளுகிட்ட யூஸ் பண்ண தெரியாத ஆளுக்கு கொடுத்தா அவர் பேங்க்ரியஸ்ல எல்லாமே ஸ்பாயில் பண்ணுவாரு. கரெக்டான ஸ்பெஷலிஸ்ட் யூஸ் பண்ணா அதை வச்சு மாடர்ன் சல்ஃபனைலுரியா எல்லாம் வெரி வெரி குட் எக்ஸலன்ட் ட்ரக்ஸ். இல்லைன்னா அது போயிருக்கும் இல்லையா? இத்தனை மருந்து வந்திருக்கு. 60 வருஷம் முன்னாடி இருந்த மருந்து ஏன் இன்னும் கண்டினியூ பண்ணிட்டு இருக்கு இப்போ? இல்லையா? ஸோ 60 வருஷம் கழிச்சு எல்லாம் இப்போ ரேடியோ எங்க போயிடுச்சு, கேசட் எங்க போயிடுச்சு, இது எங்க போய் அதெல்லாம் போயிடுச்சு இல்லை புதுசு வந்த உடனே. அந்த மாதிரி போகலையா சல்ஃபனைலுரியா? இன்னும் இருந்துட்டு இருக்குல்ல? ஏன் எழுதிட்டு இருக்கோம்? அப்போ அதுக்கு ஏதோ மெரிட் இருக்குன்னு அர்த்தம். ஸோ லெட் அஸ் நாட் த்ரோ அவே த ஓல்ட் ட்ரக்ஸ். ஓல்ட் இஸ் கோல்டு. அது எப்பவுமே ஞாபகம் வச்சுக்கணும். தங்கமணி இஸ் ஆஸ்கிங் ஃப்ளூ வேக்சினை பற்றி சொல்லுங்களேன். அவர் சொன்னாரு டாக்டர் பார்சாரதி, ஃப்ளூ வேக்சின் இப்போ ஃப்ளூ டைம் இது. ஸோ அதனால இது போயிடுச்சு, கோவிட் போயிடுச்சுன்னு நினைச்சிட்டு அப்புறம் ஃப்ளூ அதில் மாட்டிக்க போறோம். ஃப்ளூவும் கோவிடும் ஒரே மாதிரி சேம் கொரோனா வைரஸ் தான் ரெண்டும். ஃப்ளூ வேக்சின் வருஷத்துக்கு ஒரு தடவை போட்டும்போது புது இதெல்லாம் வந்திருக்கு. அவர் சொன்ன மாதிரி அந்த புது ஸ்ட்ரெயின்லாம் வந்தது. அதை போட்டுட்டு நீங்க போட்டு ஆண்டுக்கு ஒரு முறை அது போட்டுக்கணும். நியூமோகாக்கல் வேக்சின் இன்னொன்று இருக்கு. அது போட்டிங்கன்னா நியூமோனியா வராது. லைஃப் லாங், ஆல்மோஸ்ட் அடுத்த 5-10 வருஷத்துக்கு யூ டோன்ட் ஹேவ் டு வரி. ஸோ அது ரெண்டும் போட்டுட்டீங்கன்னா இந்த சீசனுக்கு இட் இஸ் வெரி குட். ஓல்டு பீப்புளுக்கு ஃப்ளூ, நியூமோனியா இதெல்லாம் தான் ஆக்சுவல் கில்லர்ஸ், நாட் ஹார்ட் அட்டாக்ஸ். ஸோ அதெல்லாம் ப்ரிவென்ட் பண்றதுக்கு இஸ் வெரி குட். முகமது ஃபைஸ், ஹவு டு லோவர் மைக்ரோஅல்புமின், அதுவும் அதே தான். மைக்ரோஅல்புமின் 3வது கேட்கிறாரு. ஸோ பிளட் சுகர் 130 டெஸ்ட் சொல்லியாச்சு. ஸோ அதை அட்ஜஸ்ட் பண்ணிட்டா சரி. ஜெயாலா, சார் இஸ் தேர் அன் ஆல்டர்னேட்டிவ் இன்சுலின் இன்ஜெக்ஷன் ஃபார் டைப் 1 பேஷண்ட்ஸ்? இருக்கு, பட் இன்னும் கண்டுபிடிக்கல. அதை கண்டுபிடிச்ச உடனே ஃபர்ஸ்ட் சொல்லிடுறோம் இது பண்றோம்னு. அதுக்கு ரிசர்ச் நடந்துட்டு இருக்கு. இல்லைன்னு சொல்ல மாட்டேன், இன்னும் வரல. ரிசர்ச்ல இருக்குது. எப்போ வரும்? 50 வருஷமா சொல்லிட்டு இருக்கோம் வரும். ஏன் 100 வருஷமா சொல்லிட்டு இருக்கோம் வரும்னு. இன்னும் வரல. அடுத்த 100 வருஷத்துல வருமா? கண்டிப்பா வரும். அடுத்த 5 வருஷத்துல வருமா? வரலாம். இதெல்லாம் நடந்துட்டு இருக்கு. நிறைய ஸ்டெம் செல் தெரப்பி, இந்த தெரப்பி, அந்த தெரப்பி, ஓரல் இன்சுலின். நேற்று கூட ஸ்போக் டு கிரண் மஜும்தார் ஷா, இது பயோகான், அவங்க கூட ரிசர்ச்லாம் பண்ணி ஆல்மோஸ்ட் கொண்டாந்துட்டோம் ஓரல் இன்சுலின், அதாவது பில். ஓகே, ஸோ ஐ ஆஸ்கர், என்ன மேடம் அது வருமா எல்லாம்? தென் ஷி டோல்ட் மீ, நோ, அது என்னன்னா டோஸ் ரொம்ப அதிகமாக தேவைப்படுது. உங்களுக்கு 40 தேவைப்படுனா 500-1000 யூனிட் போட்டால் தான் அது சேம் எஃபெக்ட். அப்போ அது அஃபோர்ட் பண்ண கட்டுப்படி ஆகாது. அதனால ஒரு டேப்லெட் 1000 ரூபா 10,000 ரூபான்னா யாராவது வாங்குவாங்களா? அதனால அது கட்டுப்படி ஆகுது. அதனால இப்போ தற்சமே அது இதில் வச்சிருக்கிறோம். பட் அகெயின் we may work on it and it may come. So Jayala, let's be hopeful. வரும். ஓகே, 100th year of insulinல கண்டிப்பா அதுக்கு ஒரு ஆல்டர்னேட்டிவ் வரும்ன்றது let us believe in it. பரமேஸ்வரி சுப்பிரமணியம், வணக்கம். Gurudev dear sir, stress has doubled in recent times. All 4 category: lockdown, media, hyper, slowdown, online, major hurdle, targets to meet, to be met, whether in thing work, pressure levels are more. Correct, I agree with you entirely. So stress வந்து நம்ம ஒன்றும் பண்ண முடியாது. ஸ்ட்ரெஸ் அப்படி வரும், நம்மளை தாக்கிறதுக்கு அப்படி வரும். அப்போ என்ன செய்யணும்? நம்ம வந்து நல்ல ஒரு ஆர்மர் போட்டிருக்கோம்னு வச்சுக்கலாம், அதை அப்படி அடிச்சுட்டு போயிடும். ஸ்ட்ரெஸ் ஒன்றும் பண்ணாது. அந்த ஆர்மர் என்ன? அதுதான் பிராணாயாமா. ஸோ யூ டூ பிராணாயாமா. உட்காந்து 5 நிமிஷம் 10 நிமிஷம் டெய்லி பிராணாயாமா பண்ணுங்க. டெய்லி 365 days பண்ணணும். வெளியில ஃப்ளட் இருந்தால் கூட உள்ள உட்காந்துன்னு பிராணாயாமா செய்யலாம். வெளியில் ஃப்ளட் இருந்தால் நடக்க முடியாது, ஆனால் பிராணாயாமா பண்ணலாம். உட்காந்துட்டு 365 days பிளேனில் பண்ணலாம், வீட்டில் பண்ணலாம், பெட்ரூமில் பண்ணலாம், எங்கே வேணாலும் சேரில் உட்காந்துட்டு பண்ணலாம். ஓகே, ஸோ அது நீங்கள் டெய்லி பண்ணீங்கன்னா உங்களுக்கு அந்த ஸ்ட்ரெஸ் வந்து அடிச்சுட்டு போயிடும். நத்திங் will happen to you. That is the secret, Parameshwari. Okay, do it and see the difference. Ravi Subramaniam, if you have chronic or acute pancreatitis, the pancreas stop producing insulin. Yes, Ravi, not acute, chronic pancreatitis. Chronic pancreatitis மறுபடியும் வரும். அது ஈச் டைம் வரும்போது இந்த செல்ஸ் தாக்கி அப்புறம் கல்லெல்லாம் ஃபார்ம் ஆயிடுவாங்க. அப்போ இன்சுலின் செக்ரேஷன் வந்து ரொம்ப குறைஞ்சு போயிடும். நாட் லைக் டைப் 1, மேபி ஒரு 10% or 20% இருக்கும், பட் யூஸ்வலி they end up requiring insulin. I've had a lot of experience, PhD, DSc, everything was on that. More than 100 publications, research papers I published on that. Anshul, hi Anshul, back again. We are targeting insulin exclusively, but there are other hormones which are also involved by feedback mechanism. So glucagon is there, other hormones are there. So you can so in the pumps that we give now, there is also glucagon is also there, insulin is also there. Sugar goes down, glucagon you can give. Sugar goes up, insulin you can give. So hybrid pumps, they are there. But ever since Roger Unger described this in 1968, glucagon has been the importance of it is known. And the DPP-4 drugs, we are actually using that. We are using an anti-glucagon agent also, but we have not used it fully. Maybe in the future it will come. Ramya Karti, is it true that prolonged diabetes, even after controlling, give complications? No, certainly no. If your sugar is under good control, you will not develop complication. That is what we have been showing again and again. That's what I am saying. I am dreaming of an India where there is no complications. Complications-free India. Okay, and I think in 10 years we can achieve it. If you all work together, get your ABCD mantra, A1C under control, blood pressure under control, cholesterol under control, and the discipline. ABCD mantra, there will be a complications-free India. So I don't agree that after 20 years, 30 years, everyone will have come. Then why treat it at all? There is no need to treat at all. Savita Vasudeva Rao, please tell about intermittent fasting. That is a topic for tomorrow. We are having the whole session on diet. So please attend tomorrow. We'll talk about that. Dr. Anshul again. For MALD, which is metabolic related, this NAFLD, new name is MALD. Does lipaglyn work, and should we stick to Pios and metformin? Don't stick to Pios. I don't use Pios at all. Okay, there are all its side effects. Just for MALD to go and use Pios and get all kinds of complications, not worth it. Reduce weight. That's most important. Do exercise. Reduce weight. And lipaglyn, metformin, you can use anyway. You will be using lipaglyn is supposed to have some. Let's wait for the SGLT2 drugs to come. I think they will work much better. Santosh Banshuli, what is the role of proteins, milk, non-veg supplement recommend? Again, we'll take it up tomorrow. Diet is the topic tomorrow. I'm not repeating that. I'm using Elvix gel. Is it advisable? Anybody knows about Elvix gel? I don't know.
It's
a local anesthetic agent, sir, combined with
for neuropathy pain.
Oh, neuropathy.
Yes, sir. Gabapentin and lidocaine.
It's a gabapentin and a lidocaine gel, sir.
Neuropathy pain for external use.
Local.
externally.
No harm in applying if it is helping you. Rajil Sawni, what does diabetes do with leg muscle? Read an article that said good leg muscles help with diabetes control. Yes, we talked about it. No, the muscle insulin is kind of its action is in the muscle, adipose tissue, liver, everywhere. So if those functions are good, especially the muscle, your sensitivity will be good. Your insulin action will be good. So that is why building up muscle and getting rid of fat is very important. So it is true what you have read. Is portable CGM like we have now today is reliable? It's very reliable. Anshul, why do you say that? It's extremely reliable. It's not measuring blood glucose. It is measuring interstitial glucose. And from that, if you take that lag into consideration, the MARD, or the mean, the assessment of the MARD, the quality of the glucose estimation is very good. It's extremely good. So you can use it. Why calf muscle pain in diabetes? More often, even blood circulation is good. Calf muscle pain may come when the blood circulation is affected. It can come due to muscle disorder. It can come due to too much of standing. It can come due to too much of strain. It can come due to vitamin D deficiency or vitamin E deficiency, or many other things. So you have to just find out what it is and treat. Somebody else also asked about cramps. What is the cause of cramps? We really don't know what is the cause of cramps. I asked 2 neurologists recently in a webinar last week. So many things work. You give magnesium, sometimes it goes away. You give calcium, sometimes it goes away. You give vitamin D, sometimes it goes away. You give vitamin E, sometimes it goes away. Control the diabetes well, it goes away. Sometimes you drink a lot of water, it goes away. Sometimes cold can produce a common cause of the cramps in the night is AC and all that. So wear socks, long stockings, and use a blanket. Very often you will not get it, but sometimes we simply don't know why it comes. So you will have to, warming up, of course, helps a little bit, but we really don't know the cause of that.
Sir, there is also one thing. There is a stiffness of the muscle. So many people will have stiffness of the calf muscle that is due to improper standing and improper footwear. We have a person who does myofascial release. So if you do that myofascial release, there is a very good improvement in the pain. So it is known as myofascial release. So we have to see whether these patients have the stiffness of the calf muscle. When you see, it will be very tender and stiff. So once you relieve that, many people will get relieved from that.
Good. So we can try. So such things help more than medication. So
high dose of statins also can cause it. High dose of statins, even that.
Statins. Yeah, I asked that to the neurologist. They said it will produce myopathy, but cramps as such as myopathy is well known. The muscle pain is well known, but more in the proximal muscles. And then when you stop the statin, should go away. But cramps due to statin, they are not sure. They're not sure it comes. So we have come to the end. Now it's 1 hour and 16 minutes, believe it or not, since we started. So I would like each one of you, since it's World Diabetes Day, I would like each one of you to give one message to the public. So we'll start with Lovelena. What is your message to the public?
Yes, sir. For the World Diabetes Day, the message to the public is control your blood sugar, do your regular checkup. That is the first thing you have to. It's not about taking it's not only about taking the medications. It's about the wholesome care. We have to treat all the complications. We have to prevent the complications. So the regular checkup is a key in treatment of diabetes. So following up at regular with your diabetologist is the very important thing for the treatment of diabetes and to prevent the complications.
Good message. Dr. Gupta, what is your message? You can unmute him.
Sorry. Yeah. So theme for 2021 to 2023 is access to diabetes care. So millions of people with diabetes around the world do not have access to diabetes care. People with diabetes require ongoing care and support to manage their condition and avoid complications. So I request government to increase investment in diabetes care and in prevention. And for all diabetes people, be stress-free and have a long life despite diabetes. Thank you.
Well done. Dr. Hani.
During this pandemic situation, most of the people will be staying inside the home. So the World Diabetes Day, my suggestion is to come out and walk and don't fear of COVID. We are almost the end of pandemic situations. Motivate yourself, do a regular walking, come out and do regular exercises and follow the diet and prevent sedentary lifestyle first. Come out of the pandemic situation and walk on the road first. This is my suggestion, sir.
I agree, and wear a mask when you do it also.
Yeah.
Okay. So, Dr. Partha.
So I just suggest one mantra that just to control A, B, C, D, E. As you say that A1C, blood pressure, cholesterol under control, D is a discipline, We even say the diet, and the E is exercise. So when you control that A, B, C, D, E, you remember that, then it's you can even win the diabetes.
Excellent. Dr. Uthra.
Yes, sir. I think each of us is very unique. Each diabetes also is very unique. So do not believe like my neighbor had took this tablet, it worked fine. My uncle did insulin didn't work. So each of your diabetes is very unique, and I think there is always a solution for every problem you have. And I think with so much technological development and research from sir and so on, I think there's a solution for all the diabetes problems until it is when diagnosed early. So treat yourself as a unique challenge, and do not generalize diabetes and get advice from the WhatsApp, Facebook, and so on without evidence on it.
Thank you. Dr. Ramu.
We do defeat our diabetes by having annual checkup regularly, meeting our doctors and do the checkup and maintain your LPMC below 7, and check your organs, eye, kidney, liver frequently, and they defeat your diabetes and live happy. This is my message to all that.
Good. Dr. Chandru.
I would like to tell that everyone, not only diabetic patient, anybody, they have to maintain their ideal body weight. That is the first thing. Second thing, they have to be aware about what they are eating and what timing they are eating. That is very, very important. Many people, they don't follow that because of their duty schedule and all. They have to follow very strictly, and it has to be every moment. It's not that today I have diet and tomorrow I'll eat whatever I want. So it has to be stopped. And third thing is they should have good sleep time. That is at least 6 to 7 hours they have to sleep. These are the three things. If they maintain, I think we can prevent diabetes, heart disease, and everything. So they have to be very aware about what they are doing. Awareness is very, very important.
Thank you. Dr. Selvakumar, உங்க கருத்து தமிழ்ல சொல்லிடுங்க.
எஸ் சார். நம்ம முன்னாடியே நீங்கள் சொன்ன மாதிரி ABCD, ஏ வந்து HbA1c 3 மாச கண்ட்ரோல் நல்லா வச்சுக்கணும். பி வந்து பிளட் ப்ரெஷர் அவங்க 120 180க்குள்ள வச்சுக்கணும். கொலஸ்ட்ரால், கெட்ட கொலஸ்ட்ரால் LDL வந்து 100க்குள்ள, ஹார்ட் டிசீஸ் இருந்தால் 70க்குள்ள. டி வந்து டயட்டு, டயட்டிஷியன் சொல்ற மாதிரி ஹெல்த்தி டயட்டுங்கிறது எல்லாமே அதை குறைக்கிறதோட ஹெல்த்தியா எது அவங்களுக்கு நல்லதோ அதை சொல்றதுக்கு தகுந்த மாதிரி ஹெல்த்தி டயட்டு. எக்ஸசைஸுங்கிறது ரொம்ப முக்கியம். எவ்ரிடே 45 மினிட்ஸ் எவ்ரிடே. நீங்க முன்னாடியே சொல்ற மாதிரி ஈட் லெஸ் வாக் மோர், அதுதான் சார் இந்த மந்த்ராஸ். தேங்க்யூ சார்.
வெரி குட், தேங்க்யூ. எல்லாரும் ரொம்ப நல்லா சொன்னீங்க. அதுக்குள்ள ஒரு 3 லாஸ்ட் கொஸ்டின் வந்திருக்கு. ஐ டோன்ட் வாண்ட் டு டிசப்பாயிண்ட் them. So Kulkarni Ambadas is asking, is it possible to control type 1 diabetes without insulin? As I said, Kulkarni, we'll have to wait, not now. I won't say in the next 500 years it won't be possible. It may be possible in the future. If you're asking today, 2021, no, it is not possible because you will die if it is really type 1 diabetes. If one or two who have told me that they stopped and nothing happened to them, I investigated them and they were not type 1 diabetes. They were wrongly diagnosed as type 1. They're the only people who can stop insulin. If you're really, truly type 1 diabetes, you cannot stop insulin because you have no insulin in your body. Insulin is like water, air, food. Can I give you everything else, but I won't give you air? I'll close your mouth and think, in 2 minutes you'll die, isn't it? If I won't give you water, I'll give you a lot of air, oxygen, but I won't give you water at all. Eventually you'll die of dehydration. I'll give you everything, but I won't give you food. I'll give you water also, but I won't give you food. That also will die. So like that, there are certain essential items, and insulin is like that. So if you stop your insulin production completely, 100%, you can just remove the pancreas insulin, and then you don't take insulin. You will die within a short time. That's what happened to all the dogs, when Banting and Best operated on those dogs. That's what happened. When the pancreas is removed, they died. So today it's not possible. But we'll never rule it out and say it will never possible. We'll wait for the day to come. But until then, continue it. Don't be misled by all these quacks who tell you that I can do this and do that and all that. They're playing with the lives of people. And ideally, they should not even be allowed to do that. There should be a law in the land which doesn't allow them to treat type 1 diabetes wrongly. That's actually, it's a crime, in my opinion. Satish Kumar, prolonged use of Reclide, does it lead to insulin? I already answered that. Sulfonylureas, don't do that. If you do it properly, use the correct dose. If you use overdose of anything, it will happen. But otherwise, I have had patients. My grandfather got diabetes when he was 44. And at that time, my father used to treat him. So he lived up to 99 years of age. 55 years he had diabetes. He took only sulfonylurea throughout his life. That we had the old sulfonylurea, glibenclamide, dinyl. He used to take half a tablet dinyl. At the age of 99 also, he was taking half a dinyl. And he lived his whole life, 55 years, without any complication. When he reached 90 years of age, my wife took retinal pictures of his, not one microaneurysm in the eye. Okay. And he continued to take it, just half a tablet dinyl, 50 years, nothing happened to his pancreas, nothing happened to any of his organs, and he lived a long and healthy life. Finally died of old age only. Okay. So it is not true. You have to treat it properly. And my father was treating him, was considered the legend of diabetes, and he was treating him, and he treated him with this only. Okay. So I've seen that. So Ravi Subramaniam, diabetes is a progressive disease. In type 2, we go to type 1 at the end of the road. If you are still type 1, there's hope to lead a healthy life. Type 2 doesn't become type 1, Ravi. It's a myth. So type 2 may require insulin to control your diabetes after many years. That doesn't make you type 1. Type 1, by definition, you'll die if you stop insulin. Type 2s who need insulin, if you stop insulin, you don't die. Your sugar may go up a little bit. That's it. So that's the difference. Type 2 becoming type 1, that is LADA. Where it was wrongly diagnosed as type 2 in the beginning, and within 6 months, 1 year, we know we're dealing with type 1. But typically, a type 2 doesn't become type 1. Type 1 is a different disease altogether. And so what if you require insulin after 20 years or 15 years? Take the insulin and live another 40, 50 years with it. No. Today we are, we are all talking about 100 years of life. Already, human beings have started talking about 150. They are saying in 30, 40 years from now, human beings will be living up to 150 years. It is possible. Okay. So you can imagine how many jobs you'll be changing in 150 years. Or if you get married at the age of 25, 125 years, you'll live with your wife. Okay. Which is good, of course. Nothing wrong in it. But I'm just saying, so you just imagine what all changes are going to occur when you start living up to 150 years. If you're born 150 years ago, there probably be no car also at that time. Okay. And from there, now we are going to the moon, and we are going. So all that you'll see in your lifetime, if you're going to live up to 150 years. But people are talking about it. It's becoming a possibility. It's not a joke. Already 115, 118, 120 people have started living. So another 20, 30 years, we're finding longevity gene. It is possible. So don't plan anything short term. Plan that 150 years I'm going to live. Doesn't matter. In between, you may leave. Like going away somewhere. Got down in the one station earlier. That doesn't matter. But we'll still plan that we are planning like that, then but prepared to go today itself. That is my philosophy. I'm prepared to go today, but actually if you ask me 150 is not bad, I don't mind staying there. But if you want me to go today, that's also fine. That's also fine. Okay. So don't have any short-term plans. Think long-term. World Diabetes Day is coming. I want to wish you all a very happy World Diabetes Day. Enjoy the day and look forward to the day when insulin was discovered. And but for that, children with type 1 diabetes won't be alive today. The greatest miracle for which Nobel Prize was given within 1 year. The only time in the history of the Nobel Prize when it was awarded within 1 year of a discovery. It's never happened before, never happened after. That is a miracle of insulin. So don't think insulin is a bad thing. For that, I'm not telling every one of you to take insulin. I'm just saying insulin is not a poison. Insulin is a lifesaver. Okay, it's like God. That's the one saving your life. So then there are lots of tablets, there are lots of diets, and lots of healthy lifestyle. But overall, it is with you. The whole thing depends on you. It is not a magic insulin, magic tablet, magic pump, magic artificial pancreas. Is not that. It's you. If you decide to have a long and healthy life, you can do it. We are all here. All my colleagues from Dr. Mohan's who have spared so much of time for you. It's my duty now to thank all of them for sparing today and evening when they could have done so many other things and come to address you. Thank you all for your participation. I'm happy that all of you have taken so much of time to ask questions and clear your doubts. Tomorrow, 9th, we have the Facebook Live session at 7 o'clock, starting at 7, and we'll be discussing all about diet. So there we'll talk about keto diet, intermittent fasting, everything that you want to discuss, we'll discuss. The next day on the 10th at 7 o'clock, again, we'll talk about pregnancy and diabetes, gestational diabetes. Then on the 11th, we'll be talking about monitoring of diabetes, continuous glucose monitoring, and all those kind of things. And then on the 13th, we have reserved for the topic of reversal of diabetes, because we'll be going deep into that and talking all about reversal of diabetes. So a lot of things planned for you. Also, on World Diabetes Day itself, you'll find numerous TV programs where we are talking, and plus social media. Those of you who have not yet subscribed to our YouTube channel or to the other, Insta and Facebook or whatever, please join, because we are going to continuously give you correct information based on scientific evidence and our own evidence and our own experience. So with that, let me once again thank all of you, and stay safe during COVID, and good night. Bye-bye.
Good night, sir.
Thank you, sir.
Thank you all again.
Thank you, sir.
Thank you.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.